Hi, good evening. My name is Dr. Nina Vinkoff, and welcome to the SBI Summer Series. Tonight I have this great panel with me. We're going to be talking about risk assessment and current screening recommendations. And before I introduce all of them and we start talking, I just wanted to introduce SBI Summer Series for anybody that hasn't been here before. The Society of Breast Imaging is hosting this summer series for the second time. We started in the summer of 2020 during the height of the COVID pandemic. And the series runs once a week. It's run by the social media committee of the Society of Breast Imaging. And our goal is simply to provide an educational forum and exchange of ideas about breast imaging topics. The topics that we talk about are of interest to breast imagers, to people who are in training, to other medical professionals, to patients themselves. Each week we discuss a different topic. Our panel, for the most part, are breast imaging radiologists, but there are also other medical professionals and even some patients and opinion leaders. And in 2021, we've switched to a different day and time. So this is our time for the most part this summer. We're going to be at 7 o'clock on Wednesday evenings. Our sessions are streaming live on Facebook, Twitter, and YouTube. And you can also see the recording of tonight's session on the Society of Breast Imaging Facebook and YouTube pages. So I'm going to just start by allowing all of my panel members to introduce themselves, and I'll start with myself. I'm Dr. Nina Vinkoff. I am a breast imager. I work at Northwell Health, which is the largest health system in New York. And I am the division chief of breast imaging and also the vice chair of our department for patient experience. And I'm just going to let my panel members kind of go around. I'll start with Gretchen, who's in the corner, and we can just kind of go around the circle and let everybody introduce themselves.
Hi, I'm Gretchen Stipik. I'm a breast imaging radiologist in Long Beach, California.
Great.
Gretchen. Hi guys, I'm Matt Miller. I am a breast imaging radiologist in Pittsburgh, Pennsylvania at Allegheny Health Network. I'm also the Associate Residency Program Director for Diagnostic Radiology there.
Hi everyone, I'm Dr. Dana Ataya. I am a breast imaging radiologist at Moffitt Cancer Center, and I'm also the section director for the USF Radiology Residency Program, Breast Imaging. Pleasure to be joining everyone tonight.
Hi everyone, I'm Telma Omofoye. I'm at the MD Anderson Cancer Center, which is part of the University of Texas system. I serve as an assistant professor in the Department of Breast Imaging and also co-director for education for the Department of Breast Imaging.
Hi, I'm Jocelyn Park, Dr. Jocelyn Park. I'm also a breast imaging radiologist at Northwell Health in New York. I get to work with the illustrious Nina Vinkoff, who invited me to be here today. And I'm also the Associate Chief of Breast Imaging at Northwell, and I'm happy to be here.
And hi, I'm Amy Patel. I'm a breast radiologist. I'm medical director of the Breast Care Center at Liberty Hospital and assistant professor of radiology at the University of Missouri, Kansas City in Kansas City, Missouri.
Excellent. We have such a great panel, and we're really representing like the entire country and some private practice folks and some academic folks. So I'm super excited to hear what everybody is doing around risk assessment and current screening recommendations. I'm just going to start by hearing about how all of you handle assessing the risk of the patients that you see in your practices. So, the American College of Radiology defines 3 risk groups. There's average risk, which is a less than 15% lifetime risk of developing breast cancer, and then intermediate risk, which is between 15 and 20%, and then high risk, which is a greater than 20% lifetime risk of developing breast cancer. And there's all kinds of factors that go into determining whether a patient is in one of those categories, be it having had genetic testing, family history, personal history, things like BMI, menstrual lactational history, pregnancy history, radiation to the chest, et cetera, et cetera. And there's a lot of different ways to determine who's at risk. There's a number of different risk calculators. There's the Gale model, the Klaus model, the BRCA-PRO model, the Tyre-Cuzick model. So my first question for this panel is, does your breast imaging facility perform risk assessment? Do you think that breast imagers are the right people to be doing risk assessment? And if you do, what model did you choose and why did you choose it? And how are you obtaining that information from your patients? Are you getting it before they come into the office, while they're there? Do you do it on a written questionnaire? Do you ask them questions in person? So we'll just start with that. And whoever wants to talk first, feel free. Anybody?
Well, at my facility in Long Beach, California, we have something called MagView. I don't know if you guys have that as well. But embedded in the MagView is the Tyrer-Cuzick score. So the way that people find out whether they have high risk is either they have a screening mammogram and MagView automatically puts in their letter that they are at high risk. And then we have somebody who actually calls each person who gets a 20 or above. And we recommend that they come in for screening MRI. We do have a high-risk clinic, but I have to say that not everybody goes to it. Mostly their referring physician talks to them about it, and then they go that way. I think it's a little bit convoluted because you get a phone call from somebody who's just a great lady, but she's just an assistant, right? Not somebody who understands a lot about what risk means. And but that's the way it's done right now.
And how do you get the information from patients? When they come in, do they fill out a worksheet? Are they on an iPad where they're answering questions?
We have an iPad and they fill it out. And many times I look at the history, I'm like, this doesn't sound right, but what the patient tells me, and there's discrepancies and I hit the wrong button, and
The other people find that too. That's actually why we didn't choose to use an iPad where we are, is because so many patients were having trouble either using the iPad or understanding what the questions meant, and so not answering them accurately. And has anybody else had issues with that, or have any other strategies that they've used to get the information?
Yeah, so we don't use an iPad. So the way that we do it at our breast center, and we have to take into account, health literacy, that we see a very large swath of rural patients, particularly in Northwest Missouri, Southern Iowa, Kansas. And so we have quite in terms of educational level, it really varies. So what happens is when a patient comes in for their screening mammogram, is our technologist actually inputs as best as they can all the information. And so we use, for our mammography reporting system, we use MRS, and it also uses Tyrer-Cuzick. So we use Tyrer-Cuzick at our breast center. And so then once they input, the technologist inputs all of that, we know what the percentage is. And just like Gretchen was saying, sometimes I will say, that doesn't seem correct, or somebody, input something. For example, when I used to practice in Boston, I had a lot of Ashkenazi Jewish patients. I don't have as many in Missouri, so sometimes when that's flagged, I'm like, that name doesn't sound like they're of that heritage. So then I have to talk to the technologist. She's like, oh, I'm sorry, I put that in incorrectly. So that happens occasionally. But once we know that they're high risk, our technologists are actually trained to talk to them. We have a pamphlet as well that we give that's called Above Average Risk, that helps reinforce the information. And then if they want additional education, one of our radiologists will talk to the patient, or even our nurse navigator. So we try to equip everybody with the tools. It is, obviously in a practice, as all of you know, of rising volumes, and we just don't have as much time to talk to patients. It can be a real challenge, but we found that because we've educated the entire team to be equipped to talk to patients, that it can help tremendously. And so if they are high risk, 20% or greater lifetime risk, we are recommending annual screening mammography, alternating with that supplemental screening, either breast MRI or ultrasound.
So in your practice, is it mainly, though, the radiologists that are speaking to the patients, or is it mainly other staff members that are speaking to the patients?
Honestly, when you really look at the percentages, I would say it is mainly the technologists, the mammography technologists that are talking to these patients. But, like I said, in some situations, the breast imagers will talk to the patient, our nurse navigators will, but usually it comes down to the mammography technologist.
Is anybody using a model other than Tyrer-Cuzick, or any of the people that haven't gotten a chance to speak yet? Is anybody using anything else?
Yeah, I'll chime in a bit here. At MD Anderson Cancer Center, the risk assessment is a huge portion of the care that we offer to patients. So there are multiple entry points to assess risk. Even though we are a cancer center, breast screening is something that's open to the entire community, even the people who have no other types of cancer, right? So as part of the protocol of patients being scheduled for a screening mammogram, they actually have the opportunity to schedule an appointment with our cancer prevention team as well. That's made up of clinicians, physicians, PAs, NPs. And so these are opportunities for some of the patients who have a family history, or they've heard that they may be at high risk, or maybe they have a certain ethnicity that's at higher risk, to kind of initially self-identify. So that's the first option, to have additional risk assessment. When they come in, we also provide them with an iPad for them to enter their information. But for every patient who we see, whether it's a screening or it's a diagnostic, they have the opportunity to consult with a radiologist at the end of their visit. And so part of that is the whole wrap up. And sometimes the process of having that conversation, it gives you a chance to get the understanding of where the patient is coming from, more details on their history, and we can then again flag them for potential more detailed assessment or an appointment with a cancer prevention specialist. And when they go to see the cancer prevention clinic or the undiagnosed breast clinic, based on their risk assessment with the Gale model or the Tyrer-Cuzick model, they may then be further referred to the genetic specialist for one-on-one personalized genetic assessment and genetic testing. So we try to give multiple entry points because the risk assessment, I think, is such a large part of what is necessary. And I think as medicine moves towards personalized care, we have to, as a community, figure out different entry points for us to figure out who's at higher risk so we can provide them the access to all the best resources.
Oh, I'm so sorry. Go ahead, Dana.
Oh, no, not at all. Please go ahead, Nina.
I was just going to ask, have any of you found any resistance from other medical professionals in your community about having breast imagers be the people that are doing risk assessment? Is it accepted in the environment that you're working that this is the right place for risk assessment to happen?
Yeah, from my experience, we are. We have a different. I have a different take on the risk assessment because of what I've gone through with this. So when I first came to Allegheny Health Network, we were doing Gale. We were doing the Gale that was integrated into Epic. Our EMR is Epic. I don't know if you all, I assume some people use Epic, right? And then there was a major push to get Tyrer-Cuzick, and that push was not only from the breast imagers, it was from also from the oncologists and the breast surgeons as well. And to kind of have that be part of the screening workup. And it worked well, we thought, for about a year or so, and until we started realizing that it seemed like greater number of people were having these high risk flags than should be. And we looked into it, and we found, first off, that some of our, so how we didn't do the iPad thing. We had the technologists, when they would come in for their screening, they would ask the questions, the technologists would put in the stuff. We have a bunch of breast centers, somewhere upwards of I think 10 breast centers. There's 5 that us breast imagers go to, and it's growing. But we do screening mammograms at least 10 places, and we found that some of the technologists at these places didn't feel comfortable asking some of the questions, and for whatever reason, we polled the people, and I wasn't privy to all the conversations that were had, but I just know from our department meetings that a lot of problems were arising because they were getting incomplete questionnaires, and they were just putting it in, and okay, well, you didn't ask nationality, you didn't ask family history, you didn't go into too much detail into your family history, ask other things. And it was basically tech error, and some of it was intentional, just because they didn't feel comfortable. So it took us a while to kind of correct that. And once we got it corrected, we found out still that we were having issues, and we found that Tyrer-Cuzick and Epic doesn't jive well together. So I'm interested to know if anybody on this panel uses Tyrer-Cuzick integrated into Epic. So right now we're in a holding pattern. We're trying to get Epic and Tyrer-Cuzick, the whatever risk stratification that puts in Tyrer-Cuzick, to kind of mold better, because apparently there was an Epic upgrade and it completely screwed up our Tyrer-Cuzick, which to me is unacceptable. But that's where we are right now.
It's really tough. I think if you're not giving out accurate results, it's really easy to lose the faith, I think, of your referring community. I mean, Jocelyn can probably speak to this because we've had some of this where, when you have IT issues that are going on, the software isn't performing the way that you think it's performing, you're reporting risk based on software that you trust. And if it turns out that you're giving out inaccurate information, you lose
a big thing.
You lose the faith of your patients. You lose the faith of the people that are sending you patients. And it's also really confusing for patients to have a patient who's high risk one year and then not high risk the following year, or vice versa.
Yep.
Is really confusing and upsetting to them, and upsetting to the people that send us patients. And Dan, I cut you off before, so let me let you get your comment in now. I'm so sorry.
Oh, no, not at all. And I think to the other panelists' comments, it's so critical that that we educate our breast imaging team. So whoever is actually participating in that information input. And for us at Moffitt Cancer Center, we do have a tablet and we do have MagView, similar to the other panel members. I saw some nods as Gretchen was speaking. And so that's incorporated as part of their appointment when they come in for a screening mammogram, and they do fill out a tablet, and a technologist does assist them with answering the questions. Now, with that said, we certainly have, similar to what Amy was describing, spent some time on education, and I think that's such a critical component. And as to your point, Nina, it's just so important to build that trust. And sometimes it's just about working out the kinks.
Yeah.
But we do use the Tyrer QSIC, similar to the other panelists. We also output a modified Gale. And so, and I think it's really important for us as breast radiologists to be participating in the identification of high-risk patients, because oftentimes, we are the first people to really identify a high-risk patient, and that's such a critical component to really getting them in the system and making sure that they get the screening that they need if they are high risk.
No, I couldn't agree more. And I think basically, I think what I heard from every panel member here is that one way or another, we are all directly communicating the results of this risk assessment to patients. We're not leaving it up to the doctors who send patients in for their mammograms. We're taking responsibility for both for providing the risk assessment and then for communicating the results of the risk assessment and what it means and what the next step should be for that patient in one way or another. I think that's one of the great things about being a breast imager, right? It's like we act like doctors. We're doctors, right? So it's and I'm glad to hear that one way or another, we all kind of agree that that's the right and responsible thing to do and part of our responsibility as breast imagers.
There was an interesting question about language barrier. I don't know if anybody caught that. Has anybody experienced that? Anybody have anything to say about that?
Well, I think that, this is part of how healthcare has to move forward. I think the question about language barriers was regarding their particular practice. They have a lot of Chinese, or I guess Mandarin maybe speaking patients, and there's a language barrier in filling out the questionnaires. This is how do you have non-English speaking patients fill out questionnaires. One of our sites has mainly Chinese speaking patients, and there's a large language barrier. What we have done is, as part of our healthcare system, we have access to translators. And so the technologists help to translate in those situations. So it's a one-on-one sort of pre-consultation with a translator to work through the questionnaire set. And then, I think to Matt's point, I think the fact that you're identifying what looks like discrepancies when you see the risk assessment, that's exactly why radiologists should participate.
Absolutely.
Right? Because when the technologists bring you that risk assessment, even if it's a patient who's not English speaking, you're able to identify something here isn't matching up. You have a central repository of information. It's somebody who can both interpret and act on the results, as well as counsel the patient. So we're in exactly the right position to be the participants in risk assessment discussions with patients.
And I know we're going to talk about this later, but the reality is that the future of risk assessment is mammography, right? All these studies
we are definitely going to talk about
MIT and IBM. The future of risk assessment is mammography, so we're going to be involved.
So, all right. So let's dig in a little bit to what our recommendations are across our various different sites. So, as all of you know, there's a lot of different guidelines that exist for, I'm just going to start with average risk patients. So let's just start with less than 15% lifetime risk of developing breast cancer. Before you even get into the high risk group, there's still a lot of debate, as we all know, about what to do with average risk patients. And I would actually like to know from all of you, in the settings that you practice, do the ACR guidelines, do the, start at age 40 annual mammography, are those the guidelines that you can recommend and feel that you have the backing of all the people that send you patients? Do your family practice OBGYN, primary care referrers, are they following those guidelines? And is there any kind of tension there around making recommendations based on what the ACR and the Society of Breast Imaging recommend, and maybe what the U.S. Preventive Services Task Force or the American Cancer Society recommends? And how have you handled that? Are you allowed to put recommendations in your reports? Are you allowed to make recommendations in your lay letters? I'd be interested in hearing from all of you.
I have a story I like to tell, and I promise I'll try to keep this brief. But within the first couple of months when I came to Pittsburgh, I read a screening mammogram and recommended routine annual screening mammography. It was on a mid-40s patient. A few weeks later, I get an in-basket message from this person's primary care doctor who says, "Why are you recommending routine annual screening mammography when USPSTF says this and we want to do it this way? And where do you get off on recommending these ridiculous things to my patients that are confusing them?" And so I set up a meeting with this family medicine doctor, and I showed him all of the data that basically states, the USPSTF came out with their recommendations based off of this, but studies have showed, and they actually agree with the fact that the ACR guidelines are the guidelines that save the most lives. And when it comes down to what we do, why we do what we do, we are in the life-saving business. And if you want to practice medicine one way, that's completely your prerogative. But know that if you're in the wanting to save the most lives, then starting at age 40 is the way to go. And numerous studies, countless studies have shown that. And even the people who are against starting at 40 agree with that.
But did you win that battle? So
I did. So that's the moral of my story. So after that, this guy, I gave him like 10 articles, and I was that guy. You know what I mean? I showed up with this binder. I was like, listen. And I mean, it was super nice and whatnot. He appreciated me taking the time to meet with him. And
but was it just a battle with that one guy or
woman?
Or did you win the battle of all your entire referring population, or are you gonna have to fight that battle one refer at a time?
So this was the only time I've actually had this argument with someone like this, and I was like, it was coming right out of fellowship. I was excited about it, you know what I mean? And so long story short, he emails me a few weeks later and was like, "I went through all your stuff." I can't say exactly what he said, but it was colorful language. What the heck is the USPSTF doing? Why are they doing this? This is ridiculous. Like complete 180, because he read the data that's out there. And
okay, but all right, so that's a great and heartwarming story. But I just want to tell you that it's not always that easy. Right?
No, you're absolutely right.
I tried for several years after I got into my job to just be allowed to give grand rounds to the Department of General Internal Medicine. Yeah. And even after several years, they let me do it. I'm a pretty convincing speaker, right? Yeah. But I spoke to them for an hour. If you call any of them up right now, and I made every argument in the book,
they say you're crazy.
Following the U.S. Preventive Services Task Force guidelines. And I'd love to hear, has anybody else had that experience? That it's not even that they don't agree with you, but they're under their own pressures and have their own metrics that they have to meet. And they're, you don't even understand necessarily the politics, especially in a big health system, of what they're being asked to do. Sure. Has anybody else run into that, either, on an individual level or on an institutional level, that our guidelines are in conflict with the guidelines of the people that send us patients?
I will say that institutionally, our referring physicians align with the ACR SBI guidelines saying start screening at 40, because between the ages of 40 to 49, there's a 15% reduction in mortality from breast cancer, right? That's the numbers. Granted, sometimes when we have referring clinicians from outside of the institution, they may sometimes have differing opinions about how screening should take place. But as radiologists, we have our own leeway to input into our reports what our recommendations are. You know, we are the experts on this issue, and so we put that into our recommendations. What I've seen, and in fact, some of the research backs this up, is that women themselves, the patients themselves, don't trust this recommendation to delay screening to start at age 50. And so when you have a radiologist report that suggests that you should continue annual screening mammography in your 40s. And then you have, news reports and even real life experiences of friends and colleagues who've been diagnosed with breast cancer in their 30s and 40s. The patients themselves are interested and eager to participate in screening. So I almost feel like, in looking back over the last few years, I feel like even the referring physicians are now being maybe driven by the patient's demands. And once a patient gets into that cycle of a couple of years in a row of getting a screen, it kind of just, the decision's been taken out of anybody's hands. That patient has owned their healthcare.
I totally agree, Toma, and I would add to that. I think my personal experience, so, being at a cancer center, similar to what you've just stated, our referring providers really follow the ACR guidelines. I think that the outside providers that I've encountered throughout my career that have recommended other guidelines, for the most part have been providers who are just confused about the differing guidelines. And frankly, it's quite confusing. It's quite confusing for patients, for most primary care providers. And so I think the breast radiologist as an advocate and doing what Nina had just stated she did. I'm sorry that it was unsuccessful, Nina. I'm so sorry, but that's what we need to be doing is more grand rounds, right? And so,
Nina, you can come to any of our sites and give grand rounds anytime.
It was a great lecture. It was really good.
I'm sure it was amazing. I mean, I gave grand rounds this past year to our OBGYN colleagues. And I can't tell you how many.
OBGYN's different though, right? So I did
OBGYN
too. OBGYN's a friendly audience.
They're very friendly. They're very friendly. Totally. But I mean, just for an example, right? You and so many of them were like, wow, that was so great. I was so confused. I was following this guideline, but after you presented the data and you showed that all of these randomized control trials demonstrated a mortality reduction of like 30% or greater, and all of these service screening studies showed even a greater mortality. I mean, like really, we understand now, and it's very confusing. And then I want to just really hone in on something that Matt said that I continue to repeat to people who are confused. All of these guidelines, irrespective of when they say start this and this, they all agree that annual screening beginning at age 40 saves the most lives. And somehow that message just gets completely lost, And so when you tell a patient that you're coming in to see and it's like, doc, I don't know what to do. What should I do? There are all these guidelines. And you tell them, actually, the research shows if you get a yearly mammogram beginning at age 40, if you're average risk, that actually saves the most lives. All of that. I mean, really, almost all of them are like, absolutely, sign me up.
That's the mic drop, right?
Yeah, you would think that everything else just gets tossed out the window, right?
That should be the mic drop.
Exactly.
It's not the mic drop, unfortunately, a lot of times. So, all right, I want to move on to a couple other topics that we are going to do a full evening where we talk about dense breast, but I am just curious to know, just kind of briefly, what if you specifically make recommendations for your dense breast patients. I know there's different dense breast legislation across the country in terms of what the official statement needs to be in your reports or in your lay letters, but in your various sites, just amongst a group of you here, what do you recommend for people with dense breast, or do you make a specific recommendation? Just for anybody listening, the ACR basically says that ultrasound, contrast, MR, any of those may be appropriate in the setting of dense breast, and actually doesn't specifically recommend any supplemental screening for dense breasts unless you include tomosynthesis. But really, tomosynthesis and mammography are basically becoming the same test. So unless you include tomosynthesis, the ACO right now doesn't specifically recommend any supplemental screening for dense breasts. So I'm going to let Jocelyn speak because she hasn't said anything. What do we recommend for dense breasts, Jocelyn?
Can you hear me?
Yes.
Okay. So we, in New York, we're one of the first states to have legislation passed where we have to inform people of their breast density, and they get a lay letter informing them that, and that just tells them to consider supplemental imaging and talk to their doctor. And we stick with ACR guidelines. We don't specifically recommend screening ultrasound or any other supplemental imaging on an average or intermediate risk patient who's dense or not.
But what happens?
Huh?
But what happens?
But what happens is everyone gets a screening ultrasound anyway. We're in Long Island, and this is what Toma said before. People are very, there's a lot of health literacy, and people advocate for more testing. We're in a culture where everyone wants more. And we have so many patients that are completely fatty, but on clinical breast examination, they're fibroglandular or dense, and they have a screening ultrasound every year. So that's where we are.
Fully 60% of our screening mammo now, 60% has same day whole breast ultrasound.
60% of your,
and that is without us making a recommendation. Even for dense breast patients, we send them the lay letter that has the New York State statement on it. But our official recommendation is mammography in 1 year. And 60% of our patients have same day whole breast ultrasound. So it's all the dense breast patients plus the people that Jocelyn just mentioned who are just like, I just want to have the ultrasound.
Is that provider fueled or is that patient fueled or a little bit of both?
I think it's a little bit of both, but more patient fueled than anything. I think.
Yeah.
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 Oh.
I find that really interesting because we recommend what you all recommend. So first of all, we do have a breast density notification law in the state of Missouri. So we have to have that in our report, and it's about the same language, kind of what you described, Jocelyn. But we only recommend that additional supplemental screening if they are deemed high risk with our risk assessment tool. Now, we see sort of I would say the converse. I think that patients who, even if they are high risk, we have difficulty with them getting supplemental screening. And a lot of it is, sometimes referring providers maybe aren't really on board with these, recent recommendations of additional supplemental screening, or, our patients really worry about the cost. So we, as of 2020, we had legislation in Missouri that's passed that would cover this if you're deemed high risk. But if you're average risk, usually in the state of Missouri, insurance is not kind to these patients. They have to pay out of pocket. So we have a lot of patients who end up not wanting it, or they have gone to a facility where they've done the screening, they're average risk, they've done breast, they've done a cash pay, and they feel like they were conned into it. And then they come to us and they're like, I don't want that screening ultrasound. So it's kind of interesting to see the differences where I practice compared to where you all practice.
Yeah. In New York, everything's paid for, because, Cuomo, like him or not for his politics, he's very pro breast cancer. And so everybody can have mammography starting at 40. Everyone can have tomo. Everyone can have breast ultrasound if they're dense. Everyone can have MR if they're high risk. Everyone can have a baseline mammogram at 35, paid for by your insurance as long as you have a New York insurer or Medicare.
Pennsylvania is very similar to that. The finances of the supplemental screening, they non-existent because everything gets covered.
Yeah.
But so my situation is kind of a happy medium between the two. We at 60%. That's so we whenever there's an extremely, so if you look at the literature and you guys might be able to chime in on this, but if you look at the literature, the strongest advocate for additional supplemental screening is it tends to get heterogeneous and extremely dense tends to get lumped in. But if you really parse down the literature, it's the strongest for extremely dense, which makes sense, right? So I personally, we don't have a system-wide. I mean, there's the Pennsylvania Dense Act that you have to give a thing, but I like free text in my impression that this due to the patient's extremely dense breasts, additional supplemental screening could be considered, is how I word it. I don't recommend it. I say And all we can, so we don't have contrast enhanced mammography. We don't have fast MR. We're working on getting fast MR. So all we have is A-bus and handheld. And so and studies have shown that one is not greater than the other, right? A-bus was all the rage a few years ago. But now we can recommend them interchangeably. So I put that, whole breast screening ultrasound, either via handheld or automated, could be considered given the extremely dense breasts. And
is anybody here recommending MRI or contrast or abbreviated MR for dense breasts in the setting of average risk? Is anybody on this panel doing that? No, it's only ultrasound if you're recommending anything.
Well, that's the discretion of the radiologist. So it's heterogeneous within the practice, but mostly falls towards ultrasound. We have a pretty robust ultrasound system, and typically MR is reserved for more significant cases of high risk.
Yeah.
Okay. All right. Well, let's skip to high risk because we're going to have a whole panel in a couple weeks on dense breasts, and hopefully maybe if you're not all on that panel, you'll write in some questions or participate offline, because I think it's not clear. It's not clear what we should be saying, what we shouldn't be saying, and which one of the supplemental modalities. And to be honest, I don't feel, and I don't say this to be critical of the ACR SBI because it's hard, but there isn't a lot of guidance out there for us to fall back on when it comes to dense breasts right now. Like, I think we all understand that mammography is not enough, but it's hard to know what the right thing is to do. So I hope you guys will all come back in a couple of weeks and be part of that conversation. So I want to skip over intermediate risk and go straight to high risk. So when it comes to high risk, in some ways it's clear what the recommendations are. Actually, we're more aligned, the ACR, with the American Cancer Society and others around what the right thing is to do for high risk patients, that it's MRI. Is there, in any of your practices, are you offering anything other than MRI for high risk patients? You're offering abbreviated MR or contrast mammo, or even ultrasound as a supplemental test for patients who are in that high risk greater than 20% category? No, everybody's offering MR.
MR.
At Northwell, we're offering contrast enhanced mammography for patients who don't qualify, or who qualify but can't get it for some reason, or who prefer to have a mammo versus MR.
I'd love to offer contrast mammo, but we just don't have it yet.
Yeah.
I mean, we offer MR. I think that sometimes for patients who, for whatever reason, MR is not an option, maybe they are severely claustrophobic, then we start to go to what are the other options around MR. I'm sorry, Amy, I think I cut you
Oh, no, that's okay. I was just going to say that at this time we do offer MRI or ultrasound. Just like Matt was talking about, we're working on having fast MRI, abbreviated MRI. We think that will help significantly too, just because of, particularly insurance plans. So, I talked about last year in Missouri, we were able to pass high risk breast cancer screening legislation, but it only falls on the purview of those who have insurance under Missouri, a Missouri plan. So if they don't have a plan out of Missouri, then they don't follow, they're not covered, which is quite a shame. So if we can, diversify our armamentarium and offer fast MRI, that could be a fantastic alternative, and of course more sensitive than ultrasound.
So I see that we're getting some questions, and one of the questions is, please urge those with dense breast tissue to get an ultrasound. My breast cancer was missed with mammography. There's unfortunately so many stories like that of patients who have only had their cancers found with supplemental screening, be it ultrasound or MRI. Quite frankly, we have our high-risk patients tend to alternate between having a mammo sono at one time of year, alternating every 6 months with the MR. And I'll tell you that most of the new cancers are found on the MR. They're not found on the sono. And but I absolutely hear you. And certainly we know that, for high-risk patients and for a lot of women, especially the high-risk people who are dense breasts, that it's not enough to just have mammography.
So I may have misheard you, Nina, because I was reading the question, but there have been studies that have shown that if you get an MRI, you don't need a screening ultrasound. There are people out there that still do it, but it's actually, there's an ACR, or it was in Yeah, it was in the JACR in 2018. They published a thing for guidelines in for dense breasts given different risk stratifications, and they basically broke it down by modality. And it says, ultrasound would be great. Screening ultrasound would be great if you are high risk and you can't get an MRI for whatever reason. But if you get an MRI, there's actually a greater false positive rate, which is detrimental. And there's no added benefit of doing the whole breast ultrasound and the MRI in the same year.
And I think you bring up a good point that we keep coming up with additional supplemental screening tools and we never take any away.
Yep,
right?
Exactly.
So we have mammo and then we had sono and then we had MR, and we're kind of hesitant to take back anything. And I have these conversations with patients where, so now we're going to add contrast mammo, and now we're going to say them have that too. And I think we do need to start thinking about whether some tests can replace others, and whether even mammography is going to be something that we need to do every year if people are able to have abbreviated MR. I don't think we're ready to have that conversation yet, but I think we need to be willing to have that conversation at some point.
The finance people hate that word, replace.
I know, I get it, but like I said, our patients are already having 3 different screening tests a year, these high-risk patients,
I think it's difficult to convince a patient who had their cancer diagnosed by a particular modality that they do not need that modality as a screening test in the future. I mean, I can understand that. I would be the same way. You will not pry this out of my hands.
No, I totally agree. I
thank you so much, Matt, for bringing that up, because I think that's just actually a really important discussion to have with our patients when we have that opportunity. If a patient is undergoing screening with breast MR, they absolutely really should not have a breast ultrasound, because it's not going to add anything. And it's actually going to, increase your false positives. And we know from the data that the PPV of ultrasound is so incredibly low, versus, comparing it to MR, which has a higher cancer detection rate, a higher incremental cancer detection rate, higher sensitivity, but also a higher PPV, right? And so I found in my experience that when I walk in to a patient room and have that discussion of, hey, I know that you were thinking you want supplemental screening. That's fantastic. Let's talk about modalities, right? So let's talk about ultrasound versus MR. And once you have that discussion, and especially kind of putting in the whole discussion about the high negative predictive value of MRI, right? If the MR is negative, wow, that essentially means that there's a negligible chance of there being any kind of clinically significant breast cancer. And once they hear that data, they're like, okay, yeah, sign me up for a breast MR. To Amy's point, I think access is an issue. So at Moffitt, we're very blessed. I mean, I think that we have an ABMR program, which is great. We also offer, screening ultrasound, but our volumes are so low. So Nina, I found that just absolutely fascinating, the percentage of patients that undergo. Yeah. I mean, I can tell you, we probably have a couple a month.
So when we build a new breast center, just so you know, Jocelyn, I can tell you, the math of it is, at the minimum, you need to have a sono room for every mammo room, and probably more than that, because a sono takes about twice as long as a mammo, and about half our patients are having sono. So if you do the math, you need to have a sono. Every time you put in a mammo room, you have to put in a sono room, and I like to have one more. So if there's 2 mammo rooms, I like to have 3 sono rooms. Wow. It's that's just the crazy environment that we work in. I'm going to skip ahead because this is such an area that I find so difficult when I'm talking to our surgical and oncology colleagues specifically. What do you do with intermediate risk patients? So the LCIS, the atypias, even some patients who have had a personal history of breast cancer who are not necessarily going to fall into that greater than 20% risk. If you've had a personal history and you have dense breast or you were young, yes, you're going to probably fall into the 20% lifetime risk. But if you're in that 15 to 20%, a lot of these patients are very anxious. What are your recommendations? Again, I feel like this is an area that our national organizations haven't given us a lot of really well-defined guidance. There's a lot of tests that might be appropriate or may be appropriate, but there isn't specific guidance about what we're supposed to be doing for those patients. I would just like to hear, what are you all doing?
We have a multidisciplinary conference to discuss some of those cases. actually. And especially the patients who are, biopsy proven, atypia, that sort of thing. And so based on the consensus decision from that conference, we kind of will decide what category that patient falls into and decide on what supplemental screening. Often it ends up being some combination of MRI or supplemental ultrasound in addition. And for us in our practice, the vast majority of patients get tomosynthesis with their mammogram anyway. But the conference is a great way to put all the minds together and try to stratify, are they closer to the average risk or are they closer to the high risk end of the spectrum, and what can we offer them?
So there isn't like one cookbook. You're really doing it on a case-by-case consensus kind of basis. Does anybody have, where you are, any kind of sort of cookbook recommendations that you use for that 15 to 20% risk category? Do you make any specific recommendations? We do not.
Yeah, I can tell you that some of the heterogeneity is with the breast surgeons.
Yes.
So one of our breast surgeons, he went to a conference last year and came back and started ordering whole breast screening ultrasounds on every patient that has had a high risk lesion. Like back in the 90s, was diagnosed with ALH at one point. This person now is getting fatty breasts, now getting whole breast screening ultrasound because whatever reason, and that was the way he told us. He was like, I went to this conference and they said that every person that's had a high risk lesion should get a whole breast screening ultrasound. I didn't look at the data that is behind that, but that was his reasoning. So it's tough. It's sometimes a moving target because there's no hard recommendations out there for us to kind of rest our laurels on, right? So yeah, I don't personally recommend anything for intermediate risk patients.
And do you think there should be? I mean, is it better to do it the way that Toma's describing, that we did it on a case-by-case basis, or?
That's super noble of you guys, by the way.
It's a lot of work.
Yes. It's more work, but I think we're going to personalized medicine. I think in a few minutes we're talking about AI, but that's where we're going. It's more work, but I think for that individual patient feeling that they have the opportunity to have multiple eyes and brains come together on their case, that's significant for them.
Yeah, I think, we found that it really comes down to what Toma was alluding to, a multidisciplinary approach and also shared decision-making with the patient. I think it's important that they're included in that discussion, particularly where we have this area of frankly gray at a lot of times. We're very fortunate where we have good relationships with our breast surgeons. We talk about these cases, what do you think, given the situation, taking into account family history, various things, how does the patient feel about it? So although it does take time, doing this on a case-by-case basis, I really do think that it helps enhance that personalized breast care that we're all trying to achieve for our patients.
I agree. When I speak to patients, a diagnostic examination, when I go speak to them, and sometimes it does come up with what should I be doing for screening. And when I talk to them and kind of inform them I feel like sometimes they're hearing for the first time that it is part of their choice. Like, what are they comfortable with? What kind of testing suits their life, or what types of risks are they willing to take, or how much testing are they willing to undergo? It's very personalized, and I think when you have that discussion with them in the room, I think it's a great role for us to initiate those conversations. And you see how it is. I think a cookbook is really hard because, like Toma was saying, personalized medicine I think is appreciated by patients.
Yeah, we have a high risk clinic.
Oh, I'm sorry. Go ahead.
Oh, sorry. We have a high-risk clinic, so when they're intermediate like that, we generally send them. For most people who come out positive with ADH, or once you put that into the score, they usually invariably make it to 20%. So they jump that, right? So
yeah. All right, we have only about 10 minutes left, and there's a topic that I want to make sure we get to before we finish up today. And we've a couple different people here have mentioned shared decision making, and I wanted to talk about shared decision making within the setting of sort of racial and ethnic considerations when it comes to screening. I think all of us here on this call know that some racial and ethnic groups, particularly Black women, are at higher risk for developing breast cancer when they're younger, for developing more aggressive breast cancer, for having higher mortality. And several years ago, the ACR and SBI issued a joint statement saying that all women should have a risk assessment by the age of 30. Now, the age of 30 is before any of us, for the most part, see these patients in our offices. And so I guess what I'd like to hear from all of you is what is being done in the places where you work to get women that risk assessment by the age of 30? Does radiologists have a role to play in making that happen?
I don't think I have the best answer for this. I want to call out some other people. Part of what we offer in our group is community education. So we talk to the community, and actually over the course of the pandemic, these educational sessions went online. So it was remote and I could talk to people across the country. So that's a wonderful thing. But in some ways, I mean, I look up to several people on this panel who use their social media platforms, right? Look at Dana, Nina, Matt, Amy, right? Like, you're using your social media platforms to reach the patients in those age groups, because the patients in those age groups are typically very healthy. They're not really interacting with the healthcare system anywhere. So I think that that's part of what we have to do. The truth is that we have a generation now where health literacy is rising and curiosity is there, but there's data showing that those patients and those humans really are looking for healthcare information on social media. So I hang my head a little bit because I'm not very good at doing this, but I think that using those platforms are going to be extremely beneficial, especially in providing this thoughtful, compassionate plea to the people in ethnicities of ethnic groups that are at high risk.
I totally agree.
Tell an 18 to 30-year-old woman, no matter what ethnic group she's in, they don't think of themselves yet as being vulnerable to illness. That group of women or men don't think of, and so how do you convince them that they need to, by the age of 30, know what their family history is, know whether anybody in their history has an illness that has a genetic predisposition? How do you get them? And maybe you're right. Maybe the right way is on social media to go to where they are, but we need to figure out a way to reach these people who are not patients yet. They're still young humans, and get them to start thinking proactively about their health.
I think having buy-in from our clinical colleagues, from family med, from internal med, from OB-GYN, having buy-in, having them, agree, having us all on the same page. That's why it's so disheartening when there's 3 or 4 different recommendations out there. But if we could all get on the same page, I think the consensus of where we go when we get these risk stratifications done, it would rise exponentially if everyone's on the same page. I think it just goes back to the beginning of what we were talking about, where there's so much out there that's conflicting that it can be confusing for patients. And if we could all get on the same page, the message would be uniform and clear, and there wouldn't be much guesswork involved.
Yeah, Matt, to your point, I completely agree. And I'm going to echo what Toma said. I think social media is just such an important component. But I think another really critical component is outreach to our referring providers. And anything that you as a radiologist can do to educate our referring providers, like our OBGYN. So I'm going to reference that talk again, but one thing that it was so surprising when I spoke to them about risk assessments and about this recommendation, right, that our patients need to be assessed for their risk of breast cancer prior to age 30, when we would initiate high-risk screening for that subpopulation. So many of them emailed me and said, oh my goodness, thank you so much for letting us know. This is not something that we normally do, but if we can't do it within our offices, at least we'll try to refer them to someone who can. And I think that it was just overwhelmingly such a positive reception. Because I think everyone's on the same page. We want to identify these high-risk women before they develop an advanced cancer in their 30s. We need to be identifying these women, and we can't do it alone. We need buy-in from our clinical colleagues.
But our clinical colleagues, I think, also are very stressed. They have only a few minutes to see each patient. As we all talked about earlier, when we talked about our technologists entering in information to get into the TyroCusick, asking these questions the right way and getting, accurate information so that you actually have a good risk assessment is time consuming. And in the setting of a 15 or 20-minute office visit where there's all these other things that you need to do, can we really expect that our clinical colleagues can even do a good risk assessment during that office visit? I've started thinking about, and there are companies out there that are also thinking about this as well, some of whom I may end up partnering with, of making it be a part of every office visit that you go, you give them a QR code or something to take patients somewhere where they can start to piece together their family history. And it usually requires more than one sitting. You're not going to get all your family history, 2 or 3 generations of family history off the top of your head. You need someplace where you can start archiving and collecting that family history and the personal history and all that other stuff so that you actually can get an accurate risk assessment. That really, it's hard to get that in like the course of a few minute conversation in a typical doctor's office visit. So I think there's only so much we can expect from them to do. It's a lot, but I think it needs to happen because there's some women who absolutely need to start at 40 and not 50. And there are some women who need to start absolutely before 40. And if we're not going to see them before 40, we got to figure out a way to get them assessed. There's so many great questions that are coming through that we never got to tonight. I've never felt so guilty in my entire life about the fact that I'm trying to talk and read these questions and not answering any of them. So everyone who's listening to this thing, I am so sorry that we are not answering questions.
We'll go through on Facebook and we'll try to answer some of them.
Yeah, and then we're just talking and not
reach out to us directly on Twitter or Instagram or Facebook.
Please do.
Absolutely.
Right to us on social media.
I mean, go ahead, Gretchen.
Sorry, again, going back to the programs, I think there's a need to reach out to the people from Epic. Somebody here, I don't know who's powerful enough that can reach out to the people from Epic. I think all of us on this panel would love to contribute because that's something that will get the patient at some point in their life before the age of 30. And then to close on that, I just wanted to know if you guys have ever looked up the area under the receiver curve for TC score for white women and for Black women. I mean, it's not great. For Black women, it's 45, 0.45, and for white, it's 0.62. It is not great. So, I mean, I think that's a huge need to make it accurate because it's just not accurate.
It's not accurate. All right, so listen, we have 2 minutes left. I want to give everybody an opportunity to make like one final point that you'd like to make before we close out. This has been such a great conversation. I couldn't thank all of you more. So great, such an engaged group and so many great different perspectives. I hope that this evening gets a lot of viewership once it's over. Again, for anybody listening who came in late, it's all taped. You can watch it on YouTube. You can watch it on Facebook. Please do. One last thought. I'll start again with Gretchen. One last final closing thought.
Again, the need for better risk assessment tools because we're basing all this extra stuff, which mind you might be paid, but most people have $5,000 deductibles and it doesn't apply to their MRI. So we need, we're sending people on this path that's so expensive, and yet our TC score is not really a great score, right?
Matt, one final thought.
First of all, thank you, Nina, for moderating this. Every time I do one of these, I'm like, oh, that's the best one that I've ever done because it just each one that we do, I enjoy more than the last one. It's crazy. Not that I didn't enjoy the other ones, but this was fantastic. So thank you, Nina. Thank you, everybody, for being on this. It was a pleasure to finally talk to some of you and to go over stuff like this. I mean, it's an incredible thing. I think this in and of itself is another outreach thing that can get to patients and get to referring physicians and educate them. That was kind of the baseline goal of establishing this is just outreach and education and going over stuff. If you are, just to kind of close up the before 30 thing, if you are below 30 and people want to know, I don't think it could happen to me. Today is the actual 6-year anniversary of my wife being diagnosed with breast cancer at the age of 29. So she'll kill me for saying this later. But yeah, so I mean, if you're looking for a real world thing, it can happen to you. It can absolutely happen to you. And it turned out she was BRCA2 and she's doing fine now, which is crazy, but which is awesome. But yeah, so my last thought is that I appreciate everything you guys have done, and this was a great discussion. Thank you.
Dana? Oh, you're on mute.
Dana, you're on mute.
You're on mute.
Thank you. Annual screening mammography beginning at age 40 saves the most lives. All societies agree that annual screening mammography beginning at age 40 results in the greatest mortality reduction, period.
Period. Toma.
Period.
I'll say, as breast radiologists, we're in a unique position because we get to see our patients and talk to them and hold their hands and walk them through stuff. Every time we have an opportunity to educate a patient about their healthcare and screening, they go on to educate their families. Our technologists go on to educate their families. So my final thought will be to the radiologists, let's not waste these opportunities to really sit down and provide clarity so that people can take charge of their health.
Great point.
Absolutely.
Jocelyn?
Totally what Toma just said. She said it better than I could have.
Hold
We
your
do
thunder.
have this unique opportunity where we have great relationships with referring physicians and patients. We're this great intermediate, entity, and I feel like we have a lot of power in that role. So I think it's great if we can wield it well.
And Amy, I'll let you finish up.
Okay, so I think that in order for us to get risk assessment right, because I agree with Gretchen, we're just not there yet. It really will take a multidisciplinary team approach. We're going to need to keep the lines of communication open with everyone on the care team, and that includes our patients. And hopefully one day we will get it right and we'll be able to save the most lives and continuing to, like Matt said, be in the business of saving the most lives.
All right. Well, thank you so much, all of you. My final comment is this was just like a pleasure and a thrill and an honor to be able to moderate this panel tonight. I agree, Matt. This was the best one I've done. So we're up in the bar now. We just got to keep getting better and better. Thank you all so much. Thank you, everyone who was listening. Please come back again. I think we're skipping this week. Is that right, Matt? We'll be back.
Yeah,
again
4th of July. We're taking a 1 week hiatus, but we'll be back the week after that, Wednesday at 7
So
Eastern.
hopefully see you all then. And good night, everybody.
Thank you, everyone.
Thank you.